Welcome to the 15 Minute to Excellence webinar series, where our goal is to provide you with useful new skills in 15 minutes or less. Today's topic is hip abductor weakness. It's part 4 of our Explosive Outcomes series. We named it Explosive Outcomes because clinicians who are able to identify these 7 underlying functional diagnoses are able to get better results than those who can't. Traditional structural diagnoses focus on a tissue source for the patient's complaint, like a facet capsule or a supraspinatus tendon. Whereas hip abductor weakness is a functional diagnosis, and that requires identification of the underlying factors that allowed it to happen in the first place. Hip abductor weakness is basically a train wreck of biomechanical deficits that can occur in the lower extremity secondary to the primary problem. So the muscles of the hip provide not only local stability, but they're also responsible for functional alignment to make sure that the femur and the tibia stay aligned during movement. Weakness and imbalance in these muscles can have a profound effect on gait and in functional performance and throughout the whole lower body, as we'll see in just a second. Especially weakness in the external rotators, or the hip abductors. They seem to have the most profound impact on lower extremity stability. The principal hip abductor is the gluteus medius. It also assists these 6 deep hip external rotators. The hip abductor, the gluteus medius, originates on the crest of the ilium, and it comes down to insert on the lateral and superior aspect of the greater trochanter. Its principal declared action is abduction of the hip and thigh, but clinicians will appreciate its more valuable contribution as a dynamic stabilizer to the hip and pelvis. In fact, the gluteus medius contributes approximately 70% of the abduction force that's required to maintain pelvic and frontal plane alignment during single leg stance. The remainder of it comes from 2 other muscles that insert onto the iliotibial band, and that would be the tensor fascia lata and the gluteus maximus, and we'll talk about those again in just a second. Incompetent hip abductors, or external rotators, will allow excessive thigh adduction and internal rotation in single leg stance. So the example on the left is what should happen, that when we lift the left leg, the right gluteus medius should contract in order to keep the pelvis level. In an example with an incompetent gluteus medius, now we can see that the muscle lengthens, it's not able to keep the pelvis balanced, and it also allows for relatively uncontrolled adduction of the thigh, which has a whole lot of problems downstream. In addition to the contralateral pelvis dropping, the excessive thigh adduction leads to increased tension on the iliotibial band, and that prolonged thigh adduction then can cause stretch weakening of those muscles as well as the gluteus medius, and it leads to chronic myofascial trigger points and irritation. So problems with greater trochanteric pain syndrome and gluteus medius tendinopathy, as well as myofascial irritation to the hip and buttock, which is present in almost every low back patient, can originate from the hip abductor weakness. But it also causes problems downstream, that weak hip abductors allow uncontrolled adduction of the thigh, or more of a knock-kneed stance. This uncontrolled thigh adduction is biomechanically coupled with femoral internal rotation, and this challenges the ligaments of the knee, particularly the medial collateral ligament and the anterior cruciate ligament. It also, as you can see, changes the orientation of the patella, pulling it laterally, causing an irritation along the lateral facet. It drives this lateral patellar facet into the lateral femoral condyle, often symptomatically, and we call that patellofemoral pain syndrome. But not all of this energy is absorbed at the knee. Some of it travels downstream into the leg. So there's internal rotation of the femur, causes internal rotation of the tibia, and that then leads to things like medial tibial traction periostitis, which we know as shin splints, as well as driving the arch of the foot down into foot hyperpronation. Hyperpronation and gluteus medius weakness are known biomechanical co-conspirators. The weakness of the hip abductors allows the foot to drop, and hyperpronation then causes further stretch weakening of the gluteus medius. So we have this self-perpetuating cycle where downstream biomechanical problems at the foot serve to exacerbate problems up at the hip. It also serves to exacerbate problems up higher. So internal rotation of the femur that occurs from gluteus medius weakness means that this T-shaped femoral head is driven backwards, Well, when that's driven backwards, it forces the pelvis to shift into anterior nutation, which then causes the lumbar spine to be forced into extension. So all of these chronic facet problems that we're seeing could very much be related to hip abductor weakness. And until we correct the hip abductor weakness, the forces on the lumbar spine couldn't expect to be eased either. So what are the complaints of hip abductor weakness? Well, now we know that lumbar spine and sacroiliac joint dysfunction, facet syndrome, but also the problems downstream that occur with the uncontrolled adduction and internal rotation of the thigh as well as the tibia. This has a direct impact on really all of the joint surfaces, and long-standing dysfunction in these joints causes what we would expect is osteoarthritis. So what do we do about it? Well, first of all, we need useful tools to evaluate it. So these are the tests that we use. These are from the ChiroUp gray box, which we'll review how to access in a second. But let's go through these tests. First of all, we're going to do a static assessment. So just a simple visual inspection to look for relative sagittal plane alignment. Sometimes we can see excessive adduction or unleveling of a hip. Sometimes we can see external rotation at the ankle or foot flare, which is a compensatory mechanism, and this is what it would look like clinically in the patient. We can also assess the Q angle. The Q angle is an assessment of the line of pull of the quadriceps, and we measure this by placing a line between the tibial tuberosity and the center of the patella and the center of the patella to the ASIS. We measure the resultant angle. It should be 13.5 degrees plus or minus 4.5 degrees for males and 18 degrees plus or minus 4.5 for females. Females have a naturally wider pelvis, which means that they're going to have an increased Q angle, and they also have more commonly hip abductor weakness. Sometimes this may be related to an altered recruitment pattern between males and females. In fact, one EMG study that analyzed gluteus medius activity during a single leg squat demonstrated that males performed the task with 77.3% maximum voluntary contraction of the gluteus medius, while females recruited only about 41% maximum voluntary contraction. So not surprisingly, females are predisposed to problems related to hip abductor weakness, especially those related to dynamic knee valgus like ACL sprain and patellofemoral pain syndrome. So most of the time, hip abductor weakness is not evident statically because hip abductor weakness is a functional problem. It doesn't come about until we lift a leg or until we start walking and squatting, so static measurements are somewhat limited. The likelihood of identifying hip abductor weakness increases proportionate to the functional demands that we place on it. So assessments that require knee flexion are more likely to demonstrate signs of hip abductor instability or weakness. Things like pelvic unleveling when you lift one leg, foot hyperpronation, and lumbar hyperlordosis. The single most basic assessment for the hip abductor weakness is the Trendelenburg test or Trendelenburg sign. And this is performed by having the patient cross their arms over their chest and lifting one leg. And what we're looking for is balance of the pelvis. Does the pelvis drop? If so, the opposite gluteus medius is likely weak. This is sometimes a learned behavior in patients, that they've had this problem long enough that they've learned to compensate, so they shift their body weight over the top of the dependent leg in order to assist that gluteus medius. That's called a compensated Trendelenburg, and sometimes it's as subtle as just swinging their arm out toward the side when they lift the opposite leg. Another test is the modified Trendelenburg, and this is performed by having the patient raise the opposite leg by raising the opposite iliac crest off the ground as high as they can for 30 seconds. And an inability to maintain that position for 30 seconds suggests hip abductor weakness. Now, more commonly, dynamic testing is going to show this problem of hip abductor weakness, and so a basic test there is a single leg squat. We have the patient lift one leg and squat down, and what we're looking for is the presence of a Trendelenburg sign to where their hip heights change. A knee valgus, which would be the most common, we're going to see this knee dive inward as it's happening in this example. It's not maintaining frontal plane alignment, it's diving toward the center. Sometimes we'll also see hyperpronation or even a foot flare. Poor balance would be another sign of instability in this case. So we can put these tests into a cluster of a progressive dynamic challenge. That is, we have the patient lift a leg and then begin to squat. We'll see some of these problems becoming evident, like the uncontrolled adduction versus a good example where the patient is able to maintain this frontal plane alignment. So let's assess this clinically and see what happens. For the following examples, patient with hip abductor weakness will be demonstrated on the left side and a patient with good hip abductor strength on the right side. The first maneuver is simply having that patient perform a single leg stance. What we're looking for is a positive Trendelenburg where the hip height drops versus the belt line staying level. The next maneuver will be a two-legged stance, and so what we're looking for here is uncontrolled adduction of the thighs where the knees are coming closer versus the patient's ability to maintain frontal plane alignment. We can make that test a little bit more challenging by having them perform a single leg squat. And what we're looking for on the single leg squat is imbalance or uncontrolled thigh adduction versus everything staying aligned basically with the crease of the pant leg in a good frontal plane alignment. And the following challenging test would be a 6-inch step down where we have the patient step up and then step down, and again we're looking for imbalance or instability as that occurs, as well as uncontrolled adduction of the thigh. Another way to assess hip abductor strength is side-lying hip abduction, either through manual muscle testing or by simply having the patient abduct their thigh while we assess their frontal plane stability. We're looking for how does the lower limb, the pelvis, and the trunk stay in alignment as the patient is abducting their thigh. This test can be helpful for patients who have difficulty performing the other functional maneuvers. Hip abductor weakness is often part of a larger problem, what we had talked about before, being lower cross syndrome, where hip abductor weakness is combined with weakness of the abdominals, along with tightness or hypertonicity in the antagonists. And so when we're assessing, we want to make sure that we don't miss a bigger piece of the picture. So once we find it, what do? Well, we're going to work out the muscles that are weak or tight through soft tissue manipulation. That includes the gluteal muscles, the hip adductors, the iliopsoas, which is commonly tight, and finally the tensor fascia lata. The other thing that we want to do is we want to obviously strengthen the muscles that are weak. So the primary goal of management is to strengthen the hip abductor. So in symptomatic patients, when we're able to strengthen the hip abductor, that correlates with improvement. And stronger hip abductors are less likely to lead to injuries. We've seen that in many studies. The most effective management tools for strengthening hip abductors would be side plank abductions with the thigh up or down, affected thigh up or down, a single leg squat, and an advanced clam. But oftentimes those are a little bit more complex than what a patient is able to perform off the bat. So our phase 1 exercises are going to ease that patient into that exercise program with things like a posterior lunge, a single clam, and if we want to make that a little bit more challenging, we can transition then into providing some resistance, a clam with a band, and a Sidebridge. And once the patient is able to perform those maneuvers successfully, now we can move into more challenging exercises like side plank with abduction, and we want to do this with the affected leg up and the affected leg down. Those are two of the more effective exercises for the hip abductors. We can move to the advanced clam, which is basically the clam being performed with the legs spread apart, and in this instance the patient is going to allow their thigh to roll so that their ankles come closer together. We also want to make sure that we're providing that patient with good ADL advice, that they should avoid prolonged static loading or stretching. So things like standing by hanging on one hip, sitting with their legs crossed, or sleeping in a side-lying position with prolonged hip flexion and adduction. Patients who have fallen arches may benefit from orthotics and arch supports, and patients who are overweight would certainly benefit from diet and exercise recommendations. So how do we implement this into practice? ChiroUp has made it simple. We're going to circle hip abductor weakness anytime that we detect that in a patient, and from there your patient's going to receive the most appropriate exercises and ADLs to make themselves an active participant in their recovery. If you'd like to review any of the assessment treatments or exercises that we covered, or to learn more about hip abductor weakness, go to the ChiroUp website, select Sharpen My Clinical Skills, go to the Condition Reference drop-down, and choose hip abductor weakness. I hope that you've enjoyed this presentation and that you benefit from ChiroUp. Thank you.